Hello, everyone, and welcome to Arthritis Talks, Managing Inflammatory Arthritis. I'm Dr. Sean Bevan, Chief Science Officer at the Arthritis Society, and thank you for joining us today. With more than 100 different types of arthritis, it's a very complex disease. We know from our many conversations with people living with or that suspect they have inflammatory arthritis, it's a difficult world to navigate. That's why we're here today, to hear from an expert and answer many of the questions that we receive about living with and treating inflammatory arthritis. About 6 million Canadians live with arthritis. That's 1 in 5 people, and that number is on the rise. You can see from the slide on the screen that arthritis has tremendous impact on people's lives. Today, we are grateful to Rheumatologist Dr. David Robinson from Winnipeg for joining us. Dr. Robinson will provide an overview of inflammatory arthritis, spend some time discussing the many different treatment options, and also touch on the future of treatments. Thank you to those of you who emailed your questions in advance, which helped us shape today's presentation. Before we get underway, just a few logistics. First, the webcast is best viewed on a laptop or desktop computer. If you have technical issues, please email support@webcastcanada.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A section at the top right of the screen, or you can email it to arthritistalks@arthritis.ca. We will try to get to as many of the questions as possible during the hour that we have together. You can click on the chat window on the right of the screen to connect with other participants and the Arthritis Society's chat moderator. If you would like to close the chat completely, please click on the icon on the bottom right of your live stream window to view the webinar full screen. I want to take a moment to thank our event partners, Novartis, AbbVie, Merck, Pfizer, United Way Winnipeg, and the province of British Columbia. This event is also funded in part by the Government of Canada's New Horizons for Seniors program. Let's get started. Thank you very much for joining us, Dr. Robinson. We receive a number of questions from people that suspect they have inflammatory arthritis or are newly diagnosed. So could you start with an explanation for us about what inflammatory arthritis is and also how it differs from osteoarthritis?
Great, thanks, Sean. It's great to be here. I'm going to advance the slide here. It's taking a little bit of time. Good, and it's really excited to be able to talk tonight. And for those of you who are wondering, because we're not wearing masks, Sean and I are safely seated at least 2,000 kilometers apart, so it should be okay. As Sean mentioned, there's more than 100 different types of arthritis, and you can see a list here on the slide. Some of those names you'll recognize as different diseases, and some of them are very rare and some of them are very hard to pronounce and spell. If we don't talk about your type of arthritis tonight, the Arthritis Society website has a nice little dictionary of the different types of arthritis from A to Z, and you can look with some descriptions of each of them as they go. So we're going to talk about inflammatory arthritis tonight, and really to try and explain it a little bit better, we have to talk about the big elephant in the room, which is osteoarthritis. So osteoarthritis is the most common form of arthritis, and particularly when we talk about seniors and other people. This is the wear and tear arthritis. It makes up about 70% of all people who have arthritis, the kind that you get as you get older or if you have injuries. And they get loss of cartilage that wears away in the bone, and you get bony nodules that form around the joints. There's lots of different causes, and about half of the people who are over age 65 have some degree of osteoarthritis. So the question is, can you have both? It's very easy to have both osteoarthritis and inflammatory arthritis if you get a little bit older. So what does it look like if you have osteoarthritis? And this is going to be helpful to compare it to inflammatory arthritis. So you get pain in the joint, usually the joint that's there, and it's usually worse with activity. So the more you use it, the more it hurts. You'll be stiff when you get out of bed in the morning, but you shake it off after 5 or 10 minutes. And if you sit at a webcast listening to me yawn on for an hour, you'll also be a little bit stiff. We call that gelling phenomenon, but it really only lasts a few minutes. And because your joints are sore and they don't work well, you're going to lose some function. So you might have a limp, you might have decreased grip strength. And the most common joints affected are the ones that are outlined with the red circles on the skeleton there, the last two sets of the knuckles, right at the base of your thumb, the knees, the hip, the big toe, and your lower back. So what's inflammatory arthritis and how does it differ? Well, this is a form of arthritis where there's significant inflammation in the joints and usually in the body as well. So there's varying amounts of redness. So you can have a big red hot toe like in the one picture, or you can see the other knuckles there are not particularly red. But the joints are usually warm. They get swollen. You can see the two finger knuckles there that are much more swollen than the ring finger. And you get activation of the immune system that we can actually measure in the blood. Now, you can get inflammatory arthritis in your spine as well, but the most common form of back pain is what we call mechanical back pain. So this it can be due to osteoarthritis of the spine, or it can be due to a disc injury, or often it's actually muscular pain because of overuse and lifting things the wrong way. And the characteristics of mechanical back pain will sound familiar to most people because it's very common. You're over the age of 40, you bend over to pick something up and you hurt your back, or you finish shoveling the snow, and it's worse with activity. That's different than inflammatory back pain, which is much less common. It often comes on at a much younger age, below the age of 40. It has a stealthier onset, so you can't really pinpoint when it started. Patients have prolonged morning stiffness that can last for hours. And really, unlike mechanical back pain, it's better with physical activity. You loosen up as you go along. So, what are the major forms of inflammatory arthritis? One of the most common is gout. You've probably heard about this. It's caused by the deposition of something called uric acid crystals in the joints, and they are usually highly elevated in the blood for a long time. And then you develop these red, hot joints, often overnight. And they hurt to even put the bed sheets on. They're very painful. And they may get better all by themselves after the course of a week. Over time, this can recur and it can actually progress to a chronic destructive arthritis in a few people. We won't have time to talk a lot about gout tonight, but we're happy to answer anything in the questions as they come up. Another really common form of inflammatory arthritis is rheumatoid arthritis. And this is a systemic inflammatory autoimmune disease. And what that means is that it affects your entire body. It's inflammatory and it's your body's immune system, which is supposed to spend its time fighting off colds and COVID and other things, gets confused and it starts to attack your joints. But it can also attack your lungs, the skin, your eyes, and a few other organs in some cases. There's some markers in the blood that we can measure called autoantibodies, and they're called rheumatoid factor or anti-CCP that we can look for that can help us make the diagnosis. And rheumatoid arthritis is pretty common. It can affect up to 1% of the population, depending on where you live. So, what does it feel like? Well, you get swollen, warm joints, hands, wrists, elbows, and instead of listing everything, I can tell you that it's not the last knuckles on your fingers and it's not your lower back. Any other joint in your body is fair game for rheumatoid arthritis. Patients have stiffness in the morning, but instead of lasting for 10 or 15 minutes, it lasts for hours. And they can be really quite tired and have decreased energy level as they go. So I'm going to tell you a little bit about some anatomy and a little bit of pathophysiology of how rheumatoid arthritis works, and it'll help us understand some of the findings that we get. So this is a cartoon of a typical joint, and you can see the two bones, and there's a really tough joint capsule that holds the bones together so they don't go flying around. And outlined in red is a very thin, delicate membrane called synovium. And synovium's job is to produce some lubricants for the joint and to help nourish the cartilage. The normal synovium you can see in the picture on the left is a nice light lacy kind of tissue. This is a micrograph done under the microscope. And in rheumatoid arthritis, that becomes thickened and inflamed, and it actually grows so that it can become actually, you can actually feel it in the joints. This is a slide from my colleague, Dr. El Gabalawi, who's been researching rheumatoid arthritis for the last 30 years. And on the right, you can see that synovium again. On the right is cartilage and bone. And what you can actually see in this slide is that the synovium is eating into the cartilage and the bone, much like a tumor. And if it's left untreated, it can cause significant destruction. This is a patient of mine who has had about 30 years of rheumatoid arthritis and really suboptimal treatment back in the day and lots of joint damage subsequent to that. Another major form of inflammatory arthritis is something called ankylosing spondylitis. Hard to spell, harder to say. So, and this is a typical form that causes inflammation in the spine and the vertebrae. It can affect the other joints as well, hips and shoulders and knees, but mostly the spine. And it is slowly progressive, and it leads to actually to fusion of the spine. So if you see the gentleman who's standing there, you can see that in his lower back, he's lost the typical curve in the lower back that people have. And at the shoulders, he's quite hunched over. Now, his spine is actually fused in that position. So when he's looking straight on at us, that's as much as he can look up, and he can't look to the left or to the right. You can imagine that's a fairly uncomfortable position. And the bone that you can see at the bottom is actually a hip joint that was taken out at surgery. And you can see where you can just make out where the ball of the hip joint is and the socket, and the joint space itself between them is filled completely with bone, and the hip is completely fused. Another very common form of inflammatory arthritis is psoriatic arthritis. This is a form of arthritis that accompanies the skin disease psoriasis, both of which are autoimmune diseases. So this can affect lots of the joints around your body, but it can also affect the spine, much like ankylosing spondylitis. And you get a few things that are unique to psoriatic arthritis. You can have nail changes, and you can see the picture of these nails where there are little tiny pits in the fingernail, and in some cases they can cause complete destruction of the fingernails and toenails. And then you also get the swelling of the entire finger or toe. And you can see in the toes there that the third and fourth toes are kind of fat and sausage shaped. And we actually call those sausage digits. And so this is one of the forms. Now, if you haven't been diagnosed yet, and I've made you a little nervous, then you can go to the Arthritis Society website, and under the Arthritis CA symptom checker, there is a list of a lot of the symptoms that I just went over for inflammatory arthritis and even for osteoarthritis. And you can go through those one by one. You can print up the questions afterwards, take them to your healthcare provider, and they'll help both you and your family doctor make a diagnosis.
So thank you, Dr. Robinson. You covered a lot of ground in those slides. It was a very, very comprehensive answer. I know we're going to get to medications in a second, but we do receive a lot of questions about how can people manage their inflammatory arthritis themselves? Does it have to be managed with medication? What can people do to help manage their disease? Maybe you can touch on that, please.
Okay, yeah, for sure. So I think before I launch into that, what I really want to talk about is what are our goals when we're treating arthritis, and particularly any form of arthritis, but particularly inflammatory arthritis. Well, the first one, of course, is we want to make people feel better. We want to relieve their pain and their inflammation. We want to maintain and improve their joint range of motion. That's how far they can move their arms up or their legs up and keep their function. Because you've seen the destruction that inflammatory arthritis can do, we want to prevent further joint destruction over the long run. And we certainly want to limit disability so that, you don't need a wheelchair till you're 300 years old or so. Now, when it comes to osteoarthritis, most of the treatment for osteoarthritis is really in the patient's hands. And I'm going to go through some of these here. When it comes to inflammatory arthritis, some of these things are just as important as they are in non-inflammatory disease. So first on the list is education. That's what we're doing right now. Rheumatologists come and go, but your arthritis is here to stay. So you better know as much as you can about it so you can help manage it. There's a bunch of other things like diet, physical activity, sleeping well, and a lot of these things that are listed there are some really, really swell resources on the Arthritis Society website under the support and education with a lot of things to help you manage them. I'm going to go through a couple of them just to illustrate some of these things. So people often ask about weight loss, and there's an obesity epidemic going on, and a lot of us are carrying a few extra pounds. And when people are told, well, you have to lose some weight in order to make your joints feel better, it can be quite daunting. But there's a deal here that is unmatched anywhere else. So, if you're carrying a large amount of extra weight, it can be quite daunting to lose it all. But you don't have to lose it all. For every pound you lose off the scale, you're going to lose 3 pounds off of each hip and 2 pounds off of each knee. What a deal. So even a 5 or 10 pound weight loss can make a big difference in how your joints feel when you're walking around. And weight loss can reduce your joint pain and protect them from further damage. It can reduce inflammation because fat cells are pro-inflammatory, particularly in psoriatic arthritis. And they can actually improve the outcome. If you need to go for surgery or joint replacement, you'll have a much better outcome afterwards. Physical activity helps arthritis. The saying is motion is lotion, right? It's going to make you feel better. And it might be something as simple as aquasizes or non impact activities like cycling or walking. But physical activity and muscle strengthening improves that strength. Improved muscle strength lowers the load on your joints. So your muscles are your shock absorbers for your joints, and that decreases the amount of pain that you get. Now, like medicine, exercise needs to be done regularly or it just doesn't work. Last year, I told my mother to start walking 3 miles a day. Now I don't know where she is. The other thing that can be sometimes helpful and your physician or your occupational therapist can help with is some of the devices that will help unload it. So splints for your thumb or wrists, knee braces, and canes for lower limb arthritis can be sometimes helpful for those.
That's great, Dr. Robinson. So we do receive lots of questions about medications, and I can already see some of them coming in through the question and answer tonight. Um, could you help us with, how do people choose and how do you decide what particular medications you use to treat arthritis? Are there different medications for different types of inflammatory arthritis? And, how do they interfere with other prescription medications that somebody might be taking?
Okay. Thanks for that. Well, so there are lots of different medications out there that we use to treat, and I'm going to start with the ones that are commonly used in lots of different forms of arthritis. So acetaminophen and anti-inflammatories like Advil or Aleve or naproxen, those are pain relievers and they make people feel better. Joint injections, sometimes we come at people with sharp objects and inject cortisone-like drugs into their joints. And those treatments will make people feel better. They'll cut a couple of our goals, like relieving pain and inflammation, but none of them prevent joint damage over the long haul. There's a side note that anti-inflammatories like Advil and Aleve and naproxen and those can actually be quite effective for some of the spinal inflammation and ankylosing spondylitis, but they don't do a lot for the joint damage in the other joints in your arms and your legs. One of the more common medications we use in inflammatory arthritis are corticosteroids or prednisone. There's some that we give as injections called depomedrol. And these drugs are really effective at reducing inflammation. They're like putting a wet blanket on a campfire or using a blowtorch on a fire. They just put out the flames really quickly. The problem with them is that they have lots and lots of side effects. So, and unlike a lot of other medications, most people who take enough prednisone for long enough will get the side effects from them. So it's just sometimes referred to as Satan's Tic Tacs by some of my patients. And so if we do need to use prednisone or corticosteroids, we try to limit it to very, very low doses or as a bridge to safer, slower acting medications. So some of those slower acting medications are what we call disease modifying anti-rheumatic drugs. And that's a mouthful. So we just call them DMARDs. Okay. And DMARDs, like those other medications, relieve pain and inflammation, but they also slow down the rate of joint damage. And they can actually, in some cases, prevent it entirely. And they're much safer than prednisone for long-term use. So although they have side effects, they have much less likely to cause side effects over the long haul. Some of the names that you may recognize: methotrexate, hydroxychloroquine, leflunomide, sulfasalazine, and we can use these sometimes alone, but we often use them in combination in order to try and get a better effect. So things you really need to know about these DMARDs. First, they're slow to work. You need a little calendar to tell you when they're actually working. They can take 6 weeks to 12 weeks to really see if they're having their desired effect. And there are side effects to them, and some people get them. Tummy upset, liver inflammation, low blood counts. And the liver inflammation and the low blood counts are reversible. So if we find them and stop the medication, they get better. But you won't have any side effects or signs that that's happening. So you often have to have regular blood tests while you're taking these medications. The other biggie here is that each of those medications doesn't work for everybody. So there's no one size fits all. So we need to do trial and error to find the right drug. And sometimes that can be very frustrating because each trial and error can last a couple of months before we know if you're going to tolerate it or if it's going to work on your inflammation. And usually we need combinations for most people for the best results. Now, importantly, the medications that I've listed there, the usual disease modifying drugs, don't actually work on the spinal inflammation. So if you have ankylosing spondylitis or psoriatic arthritis where your arms and your legs are affected, those drugs may work on the arm and leg part, but they won't work on the spine. Now, the other thing that you really need to know here is that when you develop a disease like rheumatoid arthritis, the sooner you start a patient on rheumatoid arthritis with medication, the easier it is to treat and the better the outcome the patient has. Okay. If we wait for it to go on for months and years, it is much, much harder to treat. Okay. And so lots of people are, they say, well, I can put up with it, I can manage the pain, and they don't want to try these medications. But what we do now is we really try and shoot first, and we treat people early, and then we withdraw the medications as they do well and try and minimize the amount of drugs that they're on. So we, we've used those medications for a long time, and there are a number of new types, or not so much new anymore, but a number of more advanced therapies that we have used. One of them is a group called JAK inhibitors. So you may have seen some of these advertised. So Xeljanz, Olumiant, Rinvoq. And this is a newer group of pills that you can take for inflammatory arthritis. Xeljanz has been around probably for about 10 years now, and they specifically target the inflammatory pathway. So, the scientists have really gone and looked at what molecules cause the inflammation and tried to target them. Now, They're new, so they're expensive. And because they're expensive, people who fund these, like insurance companies and provinces, reserve them for those who have failed the usual disease modifying drugs. And they do have some issues. One is that if you've ever been exposed to tuberculosis before in your life, that's an infectious disease in the lungs. It can hang out and never cause a problem until you restart these drugs. And so we screen people with a chest X-ray and a skin test for tuberculosis ahead of time to make sure they haven't been exposed. And most of us have had chickenpox, which leads us to a risk for shingles. And the JAK inhibitors of all the drugs that we're going to talk about tonight have the highest risk of causing shingles. But fortunately, there's a very good vaccine that's available, and we vaccinate people before we start that. Oops. There we go. So the other group of medications are called biologics, and these are ones that have now been around for probably 20 years. These are large protein molecules. They're very big. You can't take them by mouth because they would just get digested in your stomach. And they're, again, targeted to block some of the key molecules. And because they're big proteins, they have to be given intravenously or as an injection under the skin. And I like to say that biologic is a Greek word meaning expensive, and they run anywhere from $20,000 to $40,000 per year. And so, like the JAK inhibitors, they're limited to people who have failed usual DMARDs. And you can see that the proteins are actually made in cell cultures, and it looks very much like a brewery, the kinds of vats that they brew these things in, and then the proteins are purified and given to patients. There is this list I made up just the other night, and it's probably already out of date. There is our new biologics being used for various forms of arthritis and a lot of other diseases out there. And they often end up with a MAB or a MAB at the end of it. And so this list is out of date already, but there are large numbers of them. So it's not such a bad time to be a patient with arthritis. What do you need to know about biologics? Well, again, they're effective, particularly for those who have more resistant disease. If we start people with brand new arthritis on a biologic or our traditional disease modifying drugs, most people do well with just the traditional disease modifying drugs, and we can't really tell the difference between the two. But for people who have resistant disease, these tend to be helpful. There is an increased risk of infection compared with the older disease modifying drugs. If you're going for surgery, we usually get you to hold the drug during the surgical period, um, depending on how often you take the medication, so that you don't get an infection from your surgery. And if your doctor gives you antibiotics to take for a cold or pneumonia or something, we want to hold those biologics as well. Most of these biologics have a risk of reactivating tuberculosis, so we screen before using those as well. But we now have more than 20 years of experience with some of these biologics. And because of their cost, governments have made the companies fund surveillance programs for these drugs. We have the best surveillance data on these drugs that we have for any other medications, unprecedented safety data. The other thing that happens with 20 years is that the drugs go off patent, and we have some cheaper copies available called biosimilars. And I just want to say a couple of words about biosimilars. So biosimilars they're kind of like generic medications, but they're not really. They have the same general protein construction as the original biologic. So for example, Brenzys and Erelzi are biosimilars to Enbrel, but they're not identical in all of their structure. So they have the same protein content, but they're brewed in different vats. So I've got a picture of a couple of identical twins here. And if we took those identical twins and we raised them in completely different environments, they would still be the same in some ways, but they would be different in other ways. And so the companies have been, done clinical trials to show that these biosimilars are as effective as the original medication. and that they are safe. They are about 30% cheaper than the originals. And so the funders are making us use them, which makes sense. So if you are new to a biologic, you've never been on a particular one before, all patients across the country who are starting a biologic will need to be started on a biosimilar if there's one available for the type of drug that they're starting. In BC and Alberta, they've gone forward and they've required all the patients to switch from the originator drug to a biosimilar. Um, Now, that sounds a little bit scary, but there's been data going on in some of the Scandinavian countries and others for many years now, where they've had what we call forced switching, and it's been very reassuring. There are no signs of any safety issues, and the number of patients who lose control of their inflammation when they switch is no higher than we would expect if people continued on with the same medication.
Great. Thank you so much, Dr. Robinson. You have mentioned some Arthritis Society resources. I also wanted to mention that the Arthritis Society does have a medications reference guide that's available on our website. And we provide a lot of in-depth information about a number of the medications that you've talked about that people will be using. And people can certainly visit it at arthritis.ca and search for the medications reference guide. We'll also put a link in the chat box today. Now, before we get into the Q&A portion of today's webinar, and we have lots of questions to address, which is great, could you tell us a bit about what excites you most about the future of rheumatology?
That's a great question. There's actually a lot to be excited about. I think when I started in training, there was not a lot happening in the treatment of inflammatory arthritis. And now I'm going to answer this question in two parts. So for patients who have disease already, there are a large number of new drugs coming out. So most of the drugs that are established, we're getting biosimilars, which is great because they're driving the prices down and making them more accessible and saving all of us who are taxpayers and pay for this a little bit of cash. There are lots of different targets that scientists are using to look at ways to combat inflammation. So you go to meetings and you look at all of these targets. And in the clinical trial world where we study these things, people complain that there are more targets that we could look at than there are patients with arthritis. So there's lots of different ways that we can look at inhibiting inflammation and making people feel better. And the last bit, which is something that's relatively current actually, is that Canada has just adopted a new pricing approval system for new medications. And it's a little bit complicated as to how it works, but its goal is to lower the price of some of the brand name medications and even biosimilars when they come on the market. Again, making these things more accessible and easier to use. Now, the second half is for people who don't have arthritis yet. And this is an area that we've been working in for a long time. So we've been getting a better understanding of the onset and the causes of inflammatory arthritis. And particularly for rheumatoid arthritis, we're getting better at identifying people who are at risk of developing arthritis in the next few months. So we have a pretty good idea who can get it over a long period of time, but we're getting better at identifying people just before they develop the disease. And there are clinical trials going on right now looking at using different agents to treat people at risk of developing arthritis for a short period of time and changing their immune system around so that they never develop the disease in the first place. So a short period of treatment to prevent the disease from coming on altogether.
That's great, Dr. Robinson. So let's address some questions we've received through the Q&A today. First, I want to talk about the flu shot, and we've had a few questions around that. So the first question here is, should I pause my methotrexate and/or biologics after getting my flu shot to maximize its efficacy? And a related question, should somebody with arthritis consider getting the high dose even if they're under 65?
Right. Well, thanks for that. So that's a really good question. We've had that in our own clinic just very recently. There's a clinical trial. So first of all, everybody out there should be really getting the flu shot, unless there's a specific reason not to that you need to discuss with your physician. The flu shot is important for patients who have inflammatory arthritis and are on immunosuppressive medications. If you have an inflammatory arthritis, you're at far higher risk of complications from the flu and poor outcomes. And so it's important that you prevent that if you can, particularly in the era of COVID. Um, Now, there was a clinical trial that was done just a little while ago that looked at patients who were getting the flu shot and who had stopped their methotrexate for 2 weeks after they got the flu vaccine. And what we found was that, or what the investigators found was, is that the antibody response in the blood to the vaccine was higher in those people who held their methotrexate for 2 weeks. I've not seen any data that did this for other medications like Enbrel or other biologics, but certainly this was done for methotrexate. Now, what we don't know is whether people got less flu or had better clinical outcomes, but we know that their antibody response was higher. So the short answer about this is that if your disease is well controlled, holding your methotrexate for a couple of weeks or even your biologic for a couple of weeks probably won't make a difference in the control of your arthritis. You get 3 to 5 weeks worth of grace period before your joints start to flare. And so holding it would probably give you a better response to the flu shot, and it's not an unreasonable thing to do. If your arthritis is not well controlled, then you could suffer a flare by holding your methotrexate or your biologic. And so for those people who don't have good control of their disease, I wouldn't recommend that they hold it after the flu shot.
Okay. So still on the lines of vaccinations, there's a question here from somebody that's asking whether or not people typically get flare-ups after they have a flu shot. And also thinking about a future COVID vaccine, is that something that people with arthritis should consider, or what are the considerations around that?
Oh, good question. So most people who get the flu shot don't get a flare of their arthritis, and so they should still continue to do it. Sometimes you can get achy and sore, and I was kind of whiny and snivelly for a few days after I got mine, but I don't have arthritis. Now, because the flu vaccine and other vaccines stimulate your immune system, for a very small percentage of patients, it can cause a small flare of their arthritis. Similar to if you get a cold, that stimulation of your immune system can sometimes flare your arthritis. This is a very small percentage of people that are there. So it can happen, but it's not very common. Now, a COVID vaccine is another good question. So certainly, when the COVID vaccine is available, people with inflammatory arthritis should get it. There may be, depending on how the vaccine works, a tiny bit higher risk, depending on whether they use what's called an adjuvant or not. And an adjuvant is an extra chemical they throw in to give you a bigger immune response, so they can get away with less vaccine. And some people respond to with a little bit of a flare to the adjuvant. Now, we can always treat a flare of arthritis, okay, by giving people a little bit of prednisone or something like that in order to get them over the hump if they happen to do it. And it's not a reason to forego the vaccine as it goes.
Okay. So we've had a lot of questions here about methotrexate, probably because many people are likely taking it. Um, so a few things, if you could touch a little bit around sort of risk benefits and side effects for methotrexate in general, But also there's a specific question here about, do we know anything about methotrexate increasing the risk of either contracting COVID-19 or the coronavirus or increasing the chance of developing severe symptoms?
Okay, so let me start with the first bit around methotrexate. It's a very commonly used drug. Some people get some tummy upset. Some people feel yeah, and I actually don't know how to spell that, so it's not on any of our forms that we hand out to people. But that's how they describe it pretty well. And sometimes it can be just the day they take it or the day after. For a few people, it lasts for 3 or 4 days, and for those people, we need to find a different medication. For the people who start it, sometimes it's mild and it gets better each week as they go. But a lot of people just say Saturday's a write-off day. It's my methotrexate day, and I don't take it. Sometimes it can cause sores in the mouth. Sometimes it can cause a little bit of hair loss. That hair loss grows back even if you continue on with the medication, and it's usually pretty mild. Most people on methotrexate need to take some folic acid, and that helps prevent some of the liver problems, but also some of the mouth sores and hair loss from it. A very few people get inflammation of the liver and low blood counts when they're on methotrexate. And like as I said in the presentation, those are reversible. So if we find a problem with the medication and we stop it, it gets better, but you won't have any symptoms to tell you that your liver's unhappy. So you have to go and get your blood tested to make sure that it's fine. And for the vast majority of people who have um, normal blood tests as they go through, they really don't have any long-term problems from the methotrexate or long-term consequences from the methotrexate. There are a very rare lung complications from methotrexate that can be sometimes hard to tell apart from the lung complications from rheumatoid arthritis. And we watch for those and certainly have to deal with them as they come up. So what about COVID and what about the risk? Well, we have a little bit of data from some of the hotspots in the world, like New York City and Italy, where there were, thousands and thousands of cases all at once. And what we found is that the patients who have inflammatory arthritis are not dropping like flies. So they seem to have no higher risk than the rest of the population. They certainly have the same issues in terms of age, male sex, underlying conditions like diabetes or hypertension. But it's really hard to find a much higher risk of severe complications from COVID with the typical disease modifying drugs or even some of the biologics. The one exception to that is prednisone. So patients who are on more than 10 milligrams a day of prednisone seem to have a higher risk of contracting COVID and a higher risk of complications from it.
Okay. So you did touch on this in your presentation around osteoarthritis and inflammatory arthritis. I think one point of clarification, which I think I mentioned about the 6 million Canadians currently living with arthritis, and the question was around, are all of those people living with rheumatoid arthritis? No. We actually know that the most prevalent form of arthritis is osteoarthritis. But another question here from someone who has both osteoarthritis and rheumatoid arthritis, can one aggravate the other? How are the treatment options? Are they the same for both? And how common is it actually to have both OA and RA?
Yeah, it's actually quite common to have both, but don't tell anybody because everybody in my waiting room will want more than one form of arthritis and be special. Um, the Now, can one aggravate the other? Well, certainly, if you have osteoarthritis and you get inflammation from rheumatoid arthritis in that joint, it can make the osteoarthritis progress much faster. And in patients who have rheumatoid arthritis for a little while and it starts to make some damage in the joints, even if we wave a magic wand and cure their rheumatoid arthritis, which I don't have a magic wand, so I can control it, but I can't cure it. If we make all the inflammation well controlled, then the damage that's there can progress and end up looking like osteoarthritis in that joint. So osteoarthritis is sort of the end form of all sorts of joint damage and insults. So it is very common to have both, particularly since half of the people over 65 have some OA.
Mhm. So then on the same theme around related conditions, if someone has lupus, does rheumatoid arthritis come on automatically?
Oh, yeah, that's a really good question. So we didn't talk about lupus very much. Lupus is really the quintessential autoimmune disease. So it's called the disease of a thousand faces because your immune system can attack just about anything, and patients can have a hugely varied presentation. And arthritis is one of them, and it's a very common presentation to have arthritis. Now, it's a different disease than rheumatoid arthritis. It has different genetics and it has different issues that occur with it. Um, the and so if you have, there are very, very few people who have an overlap between lupus and rheumatoid arthritis. We call it rufus, and they seem to have very typical rheumatoid arthritis and then also have lupus. But the two are not necessarily come together, and in fact, usually don't come together.
Okay. Um, could you speak a little bit, elaborate really on your last points around research being done right now to customize treatments for rheumatoid arthritis?
Oh, yeah, it's a good point. You know, the holy grail of treating people who have established disease would be knowing exactly what drug Sean needs for her rheumatoid arthritis. And we're not there yet. So we're still a long way away. And it would be marvelous to be able to say, I know exactly what personalized cocktail of poisons we should give you in order to make you better so that we don't have to do this trial and error process. Lots of people are working on it, doing genetic studies and combing through clinical trials to see what things work for particular patients, but we're really not there yet.
Well, picking up on what you just said around genetic linkages, there's a question here from somebody who has OA and RA and also a family history. So, what do we know about the genetics of rheumatoid arthritis in particular, or arthritis in general, and how it develops or risk factors?
So OA is a little bit genetic in that you can blame it on your mom or your dad, and particularly the kind that affects in the hands with the knuckles and in the fingers. Um, and because it also is associated with obesity, and obesity has a genetic component to it, there is some genetic component to that. RA has a much better linkage in the genetic side of things, as far as I'm aware. So there are certain genetic markers that predispose people to developing rheumatoid arthritis and account for about 30% of your risk. Now, most people don't have a family history, but if you have a first degree relative with, well, let me rephrase this. The risk of developing rheumatoid arthritis is about 1%, a little bit less. If you have a mother or a father or a brother or sister who has rheumatoid arthritis, your risk goes up to about 3% or about 3 in 100.
Okay. So there's a question here. The question is why does arthritis twist fingers? I think speaking to the physical characteristics of the disease. Could you explain that a little bit?
Yeah, so that's a lot of mechanics and a lot of muscle pull. So what happens is that when the joints swell, the ligaments that are supporting them become disrupted and broken and stretched out of place. And so even if you take your hand and you put it in front of you and you make a fist, you can feel that the fingers are pulled a little bit off towards the baby finger side. And if you have damage to your wrist where it turns to your thumb side, and then you make a fist, it pulls even more to the baby finger side. So that's often a common question that people have because they will have not gotten put on therapy or not taken therapy early on in their treatment, and they will have suffered that ligament damage in their fingers. And then their fingers start to twist and they say, I really want to start some treatment now. And it's too late to stop the twisting because the damage to the ligaments is already done. But we can treat the inflammation.
So there are a few questions here from people who have been on medications for a long period of time. So two related things, one around the safety of many of the medications that you talked about. Is it safe to be on these for a long period of time? And then when you're not having symptoms anymore, is it safe to wean yourself off?
Oh, those are both really good questions. So, long-term safety is pretty good. Now, we do know that over long, long periods of time, some of the medications like methotrexate and some of the biologics have a very slight increased risk of particular cancer called lymphoma. And they have an increased risk. Anything that lowers your immune system has an increased risk of the kinds of skin cancer like basal cell and squamous cell cancer. Not the ones that necessarily kill you, but that you got to get, frozen off your face and are related to age and sun exposure. They sort of double the risk of those over time. Long-term treatment. Now, you have to compare that um, if you don't treat rheumatoid arthritis, it has its own mortality risk that is a great big gorilla in the room. So, we used to say that patients who had rheumatoid arthritis had 10 years taken off of their lifespan. And that was, mostly from cardiovascular disease or heart disease. And so if you have rheumatoid arthritis, your risk of heart disease is higher. And if we treat your rheumatoid arthritis, that risk, if you respond to the treatment, actually goes back to baseline. So you can reduce that risk by effective treatment of the rheumatoid arthritis and other inflammatory arthritises. So there is some danger in long-term treatment of medications, but it far outweighs the danger of not being treated. So what about taking people off drugs? So if I'm sitting around and I'm looking at Sean and she hasn't had a single sore joint in 5 years and she says, why am I taking this stuff? Then what we've been doing over the last couple of years is actually backing people off of their medications. So we lower the methotrexate, we might stretch the biologic injection out, and this really, really needs to be done in cooperation with with your rheumatologist or your specialist, right? You don't want to be doing this on your own. Talk to them about it. Most of the rheumatologists are up on this. They're going to be lowering people if they think they're under good control. But you have to be under good control for a couple of years, okay? Otherwise, you'll just get worse again. If you're still flaring in between your visits with your rheumatologist, then you may flare as well. Unfortunately, the vast majority of people, if we take them right off of their medications, will eventually flare again. And so only about 2 to 5% of people in the trials where we've tried to back people right off of their medications, even though they've been in remission for a long time, will be able to stay off of their drugs.
It sounds like a careful risk benefit dialogue to
Yeah.
treating clinician.
And I think most important is the dialogue part of that. So you really need to be talking to your specialist and discussing when to do that.
Okay. So switching gears a little bit, could you touch on the role of diet in osteoarthritis and maybe in general actually for arthritis? Do certain foods affect symptoms that we know of?
Oh, yeah, this is a tricky one because there's a lot of stuff on the internet, and there's a lot of stuff that is there. There's a little bit of information on the Arthritis Society website that's helpful, and even some recipes if you're into cooking.
Mhm.
Um, and we don't know for sure that there's a lot of different foods that can affect arthritis. So we have a couple that we know of. So one is that we know that omega-3 fatty acids, and those are found in fish oils and flax seeds and things like that, have a bit of an anti-inflammatory effect, and they can help a little bit. They're also, likely good for heart disease and things like that. So helpful to utilize those. There's a little bit of data around curcumin, and curcumin is one of the ingredients found in turmeric, which is an Indian spice. Turns everything in your house yellow if you get it on things.
Mhm.
And turmeric in animal studies seems to reduce inflammation. We're actually embarking on a federal government funded study looking at turmeric in some of our at-risk patients with arthritis to see whether it has an effect on their biology as we go. And there's a lot of data in animal models about salt and high salt diets being pro-inflammatory. And this is particularly in the case of patients who have ankylosing spondylitis and psoriatic arthritis. The particular molecules that drive a lot of that inflammation seem to go up in people on high salt diets. So better for your blood pressure to be on low salt diet anyway. So certainly something to be avoided.
Okay. I have a couple questions here about related conditions. First of all, could you clarify fibromyalgia? Is it a type of arthritis or is it not?
Uh, Good question. It's often linked in as a type of arthritis, and it is commonly occurs in people who have other forms of chronic arthritis. So it, it's and it wasn't quite clear as to exactly what it was, but we're getting a better handle on what actually causes fibromyalgia. Fibromyalgia is patients who have very widespread pain, and sometimes they have very typical tender spots on their shoulders or their chest wall. And sometimes everything hurts and it disrupts their lives, really. And what we've seemed to have found is that fibromyalgia is a problem with the wiring system. So the pain that people feel is real, but the problem isn't in the joints or the fingers. The problem is really in the nerve signals as they go from your fingers to your brain. So if I poke my finger with a pin, it sends a signal to my spinal cord, and then it goes to my brain, and my brain says, ouch. But it doesn't work that way. When it gets to my spinal cord, the nerves in my spinal cord, well, they look at it and they process that and they change it around. And in patients who have fibromyalgia, they turn up the volume like an electric amplifier and they send that signal up to your brain. Now, sometimes if you have arthritis in a joint, that can make the fibromyalgia much worse because the signal that goes is much worse. But sometimes fibromyalgia comes all on its own. And so we have to treat it a lot differently than we do some of the other arthritises.
Okay. I want to come back to this question around COVID-19, just given the world that we're living in right now. And just to be very clear about whether or not any of the medications people could be taking or likely taking for arthritis would make them at greater risk of contracting COVID-19. And there's reference here, around the susceptibility to infections that people would see on their drug monographs and things like that.
Right, right. It's hard to predict, okay? And this is an imperfect world where we don't have tons and tons of information, and we haven't been walking around purposely exposing our rheumatology patients to COVID to find out if they get sick. Patients who have a high rate of infections on their current medications, if it's bladder infections or sinus infections or skin infections, may be at higher risk of developing infections with COVID-19. Um, we have really recommended, even though I've tried to be as reassuring as possible with the data that we've had from Italy and New York, we do recommend that people take precautions with when they're on biologics and when they're on methotrexate and other immunosuppressives to not get this disease. Now, it doesn't necessarily mean you have to. Now, I used to tell people they didn't have to walk around in a bubble, but we're all in a bubble these days. So, yeah, keep to your social bubble and keep socially distant and good hand hygiene and be careful. Um, but none of the medications apart from uh, prednisone seem to be particularly risky that we've know so far?
That's great. Thank you, Dr. Robinson. I feel like we've covered a lot of ground. I also feel like that was a bit of a rapid fire, but I hope we got to many of the questions that we have from our viewers. So thank you so much for sharing your expertise with us today. The video and presentation slides will be emailed to all of our registered participants this week, and the recording of this webinar will be posted to our website very shortly. We'd like to take just a few moments to get your feedback on today's presentation. So those of you on a laptop or a desktop, you'll see another poll question come up on your screen with a yes and no answer. So please do click on the response that reflects your thoughts. And the question is, did you find the information in today's webinar helpful to you? We'll be sending an evaluation form when we send out the video. So if you're unable to access the poll questions, certainly you'll have the opportunity to provide feedback then. Once again, thank you to our sponsors, Novartis, the Government of Canada, New Horizons for Seniors Program, AbbVie, Merck, Pfizer, United Way Winnipeg, and the province of British Columbia for their financial support of this event. We invite you to support us as we continue to create valuable resources to help you better manage your arthritis. If you are able, please do consider visiting arthritis.ca/donate. Our next event, Arthritis Talks, Complementary Therapies and Emerging Treatments, featuring rheumatologist Dr. Marianne Fitzgerald, is coming up on Thursday, November 26th. To register for that event, please visit arthritis.ca/arthritis talks. This concludes Arthritis Talks, Managing Inflammatory Arthritis. On behalf of all of us, thank you for joining us today, and please do stay well.